So I am going to move on to our very next speaker, a speaker that I'm very, very proud to know and work with, Professor Samar Aoun. She is our chair of the Southwest Compassionate Communities Network. And today she's going to be talking to you about the Community Connector project, which was that short film that we showed you at the start of the day. But let me tell you about Samar. Samar adopts a public health approach of model of care and advocates for person-centred health and social care. And I have to agree with that, is for someone that's so academic, she very much has a very personal approach and a real passion for community work. So her research programs on supporting family caregivers at end of life and the public health approach to bereavement care have informed policy and practice at a national and international level. She co-founded the Southwest Compassionate Communities Network in 2018 and is the current chair and is leading the Compassionate Connector project in partnership with WA Health. In 2018, Samar received the Medal of Excellence from the European Society for Person-Centred Healthcare. So please, let's welcome Samar.
Well, hello again. You know, I just want to comment a little bit on leadership. You know, Bonnie said something really important. I think that's the way I see leadership. It's like having a flock of birds flying in a V formation, and they do this for a purpose, is they all synchronize their flight. Now, at a certain time period, you've got the one at the front gets too tired, goes to the back, and the next one comes in. And I think this is how it needs to be in communities, because as Bonnie said, you know, life gets in the way. You're not in a position to lead sometimes, and that's fine. You just support, and then you've got the next leader coming through. So I encourage as many people as possible who are able to take part in our work to come forward. And again, we need so many skills to make this place a better place to live, but also to die. I keep saying this, you've heard me saying it before. I'd like to acknowledge the co-founder with me in 2018, Dr. Julianne Hilbers. We connected as community members because we were discussing how our fathers died, and of course we thought, oh, there was a better way, at least for mine anyway. And we started this with really, you know, we're very grateful for the funding that we got from WAFA, WA Primary Health Network, and Kate Cross was a major supporter, and she got us really going. She was like the wind beneath our wings to start off with, in a way. So everyone, you know, has their bits. And of course, I'd like to, you know, thank the Lomax for the wonderful video. You already know about the Connector project. This is such an amazing way of introducing it. And Mary and, you know, the stars of it, Mary and Jenny, you've done an excellent job. Thank you as families for taking part. It's really difficult. It's not an easy thing. But at least you've shown how it works, which is great. Better than I'm able to explain anyway. So that's fine. Oh, I forgot. I need to start really talking. Otherwise, Leanne will kick me out. So this project was, okay, so these are the lovely ladies of the first training connector session. And Leanne and I did the training for these ladies. Then we had another batch. So why is this so important? And of course, when the Productivity Commission report came in 2017, Palliative Care Australia, our peak body, said many Australians are dying in a way and in a place that doesn't reflect their values or their choices. And their end-of-life journey is punctuated with avoidable or unwanted admissions to hospital with the confusion, loss of dignity, and loss of control that comes with it. So certainly we can do better as a community than having this kind of scenario happening to our loved ones. And then again, we are quoting Alan Gallagher. He's a really big figure in the field. Death is a social event with a medical component. It's not a medical event with a social component. That's why this is our responsibility to make death experience much better for everybody and for ourselves when the time comes. So, and again, Alan talked about the 5%. You know, I found this, somebody else said it's 10% of our day is in contact with formal care, whether doctor, nurse, you know, social worker, pharmacist. And, you know, the 90% is really informal care whereby spouse, caregiver, family, friends, community agencies, municipalities, this is where we are spending our time. But sadly, as Alan said, some of us spend it on our own. And this Connector project had showed how many isolated people are. They only want somebody to go and talk to them and have a cup of tea with them. It's really sad that this is really happening in our communities. So that's basically at what's sort of why we started this Compassion Community Network, where everybody really knows what to do when somebody is crying, dying, or grieving. These are the 9 groundbreakers that Jessie talked about, so I won't dwell on that. So it's a lovely concept, compassion communities, but does it work? If you go and ask for funding from anybody, that's the first thing they ask you. Show us how it works. I mean, we understand like it's really good, but so this is why we set up with the WACS, WA Country Health Service, to do an evaluation of the project here in the Southwest. So we've implemented and evaluated what we're doing, a model of community volunteers that support people in advanced illness and palliative care needs, a training program again, because it's really important to have everybody working together with the boundaries that we have set, because every one of you is doing this in the community. But I think what we've noticed with the connectors, they're really happy to be part of a community that care and help each other and support each other rather than working in isolation. And again, of course, the end of it, we really want to know whether this has worked from a qualitative perspective by interviewing the connectors, the families, and also the health professionals. So what are we aiming to increase is the social connectedness of the community, hence why we've got the title, Let's Build a More Connected WA. And we have this tool that will measure if we have improved this before we started the program and after. So the higher the score, the more people feel more connected. The other secondary outcomes, which are really important, also for health providers, decrease in hospital admissions. You don't need to be in the hospital, when you die. Decrease in caregiver support needs. The carers are doing enormous amount of work to help their loved ones. Increase in advanced care plans, you'll be pleased to know. We're trying to actually, get people to have those conversations. It doesn't happen all of a sudden, but it needs to happen slowly. And of course, if they're satisfied with what's happening. So the role of the connectors, they're not the ones who are doing it for the families. They're the ones who are assisting the families to find who is in their neighborhood who can help, and that's more sustainable on the long term. So they will find out from the families what are their social and practical needs, and therefore make sure that they are well connected with the formal and informal services in their communities. And this is where they circulate within these models of circles of care. You've got the person with the illness and the family carer at the center. Then where are their informal networks, whether inner, outer, or communities? Sometimes some of them don't have them, although they are around them. So we're trying to keep now connecting them. But the key issue is for those families to know how to ask for help. And this is what we've lost in the Western culture. We really think we can do it ourselves to our detriment and the detriments of our society. Because if you ask for help, you're really doing a favor for your communities to get the skills that are needed to help you and help others down the line. Otherwise, if they don't help anybody, they have no practice. So now the connectors find what we call in the community the caring helpers. And these could be family, friends, neighbors, that the families themselves in need don't have the courage to ask. And it could be like needing to walk the dog or doing the shopping or collecting prescription, anything that's, we need to do in our daily life. We published a protocol so that, this is very academic, but so that everybody who's not here can read what is it that we're trying to achieve. We had 28 community members really interested, but we didn't go far and wide in advertising this because we only went to the ones who attended our educational programs because we knew they had a certain level of good death literacy and grief literacy to start off with. And there is a postcard on your table whereby if you leave your name and details and you want to do something for the network or your community, we can then allocate you if you want to be a connector or a caring helper or just on the committee or anything really. So we've trained 20 connectors through 2 training sessions. The training program really included understanding the public health palliative care approach and compassionate communities, understanding advanced illness and the role and capacity of the palliative care team, death literacy, advanced care planning, the WACS program rules and regulations for volunteers, communication skills, confidentiality, self-care boundaries and endings, and of course the research protocol, the process and evaluation tool, which was really very boring, you know, for volunteers. But thank you for connectors for collecting the data. Without this, we cannot prove that it's worked, you know. I mean, they understand this, but it's such a, something they don't like doing. Nobody likes, except me probably. Anyway. So when we looked at the pre and post training for the evaluation, you could see the green one is after the post the training, and the blue one is the before the training, and this is the increase in their confidence, and this is the very confident. So we had people who were very confident anyway, but then again, what we've done in certain items, you know, they've really increased their self-confidence to actually do that kind of work that we're asking them for. And again, this is another show. I won't go through the details. So we had some comments from connectors after the training. It was great to talk freely about death like-minded people. The resources provided were great. Everybody is kind, caring, compassionate. Would love more training and catch-ups. Great to have access to information and knowledgeable facilitators in end of life and grief, and being a valuable community connector. Resources are amazing. So we're building this in the community, and it stays in the community. So these connectors, you know, are there, you know, for the community to be able to ask for their support. So this is the domains where basically the connectors now try to connect the families. Personal care, medical, whether going to appointments or explaining medication or linking with doctors. Home, transport, social, food, pet animal, you know, and also preparation for end of life. We've got also community directory that helps connectors to see who else they can refer to. This is the cycle over 12 weeks. This is only for the research purpose, so that we can just get the information over 12 weeks, and then, you know, the connector moves to another family and so on. And the idea is to basically find out from the family who they think they've got caring helpers around them, and then they contact those caring helpers and make sure where the need is. Very much like Tony's video, what you've done in Albany there, is like mapping for the family who's going to come when to help them with what. So we've started, palliative care service started referral in July last year, and then we've added another stream from chronic disease service this year. So within 12 months, we've had 61 families referred, 23 declines for all sorts of service reasons, and then we got now 25 families participating. So really it's 41% recruitment rate. It's the case in research in palliative care. You never have really, you know, high recruitment rates for a lot of reasons that, you know, they're overwhelmed with already people who are there, treatments, appointments, you know, frequently in hospital, too late in their journey, want to be with family alone. You know, it would have been useful during the treatment journey. So, you know, everyone says something different too. I mean, COVID-19 didn't help because they don't want people now to go to their homes and see them. But we do a lot, you know, the connectors do a lot by phone, by FaceTime, by, you know, texting. It's not just, you know, face-to-face all the time. And we're also trying to spread the message for communities to refer on to the project as well. So, for instance, with 25 families, 15 were female, 10 were male, average 73 years. Now, the interesting thing is that 60% were home alone. That's a high percentage that's referred to this. And the primary diagnosis, cancer, COPD, heart failure, and neurological. The carers, again, similar age group, 75 years, mostly retired. For instance, one family who is a female, 87 years, has got CVAs and cancer. Their social connected scale when they started was 29. When we finished with them, it was 39. So this is the higher, the better. So that's good. Her husband is really frail at 92. No family close by, unable to see them also because of COVID. They've got a network of friends, but not willing to ask for help. This is a major problem, you know, with these families. So basically, the connector has done 12 visits to the family in general, 13 phone calls, and then to their networks. And they've organized 4 care services through My Age Care, arranged an ACROD parking permit, talked about advancing advanced care planning, the paperwork, particularly the AHD and EPA, established their neighbors' web networks again, social visits, and it seems they sourced a jar opener because the lady couldn't really, maneuver whatever she's got. So in total for the last year, there were 514 encounters with families, which is 189 hours between the 9 active connectors. Obviously, not all connectors were able to actually carry on with us, again, for life standing in the way. So in general, this is the kind of work that the connectors have done. I've mentioned some of them, but equipment access, meal delivery, assistance to join community groups, all time dancing. Sean, she did a good job for this guy who really wanted to dance. Transport, alert, pending information, pendant, gardening, firewood delivery, and the empowerment and the ownership. You can do this. This is what the families have benefited from as well, which we can elaborate a bit later. So as a project team, we keep in touch with the connectors on a fortnightly Zoom meetings. I tell you what, we learn so much from them. We just listen. I mean, they're fantastic people. They're just amazing what they do to these families. And of course, Robin, my research assistant, had done the interviews with 7 patients' carers, 7 connectors for health professionals. And then one of the questions about what do you think the impact has been on the patient or the clients, the families, in terms of coping with daily activities, improved formal access, increased community links, increased social activity, and reduced social isolation. So the blue one is what the clients have said. So at the bottom, it goes from not at all to a lot. So as you have seen, there is, it tends to be between quite a bit and a lot. But the interesting thing is that the clients have rated what they've benefited more than the connectors thought they've done. The connectors are underestimating their role and what they are doing to those families. So well done, connectors. So some of the quotes that the patient and carers feedback always keeps her promises. A lot of paid carers really don't care, just filling in the hours. She goes above and beyond and seems to care. She knew when we were a bit overwhelmed, knew when to get involved and when to step back. Necessary for people who don't have strong existing networks. For people who are isolated, it will help open up their world. And literally, this is what's happened. I can ask her anything, no matter what I talk to her about. She's always has a sensible answer. One of them said, pretty amazing. And then this is one of the caring helpers helping with, and she told her, she's my legs. The connectors themselves said about this project, great to be given someone specifically to help fill their needs and tick their boxes. So rewarding to watch their quality of life improve. Being able to connect volunteers to those in need has brought very obvious benefit to both the volunteers and the receivers. The more you give, the better the reward. The reward is greater than the effort. Fabulous program. The healthcare team, really positive, especially for clients who are early in their journey and for those who are isolated and don't have good family support. I will be encouraging more people to make use of informal networks and support. She's very socially isolated, and our professional service is not enough to meet her social needs. So I'm very happy for her that she has a consistent person to talk to. Yeah. Added another string to our bow, especially in small rural areas where there is a lack of formal services. Easy to implement, which is great. I mean, this is a partnership with the palliative care team here who have been fabulous supporting this project. So, Gabriella, we go back to this beautiful diagram. How do we all fit in with a public health approach to palliative and end-of-life care? And this came out of the palliative care review I led for WA Health late last year. How can we all connect those dots? We've got all these services on the right who needs integrating, and families are doing a great job at doing those integrating, whether NDIS, aged care sectors, specialist palliative care, generalist palliative care, and so on. Then you've got the enablers, and this is where the compassionate communities come. They're enabling all these integrations happening to people and empowering them to be there, connecting to everything else. And of course, advanced care planning and the education that needs to be done. This is all part. This is the model of care that we need to strive for. It's not just clinical care. It's because no matter how much money you throw at a system, the community, if the community is not involved, it's going to be always expensive and always unsustainable. And this is where the community is important in this. So I'd like to really thank everybody who's been part of this project, the project coordinators, research assistant, Leanne, the Compassion Community Connectors. Can you please come on stage so that we can really, thank you, so that people know who you are. And while I'm mentioning all that, so Jenny, Heather, Helen, Tony, Di, Janine, Sean, Anthea, Frida, Onawi, Jeff, Halcyon, and Luke. I know a lot of you are here, so please, come on stage so that people know who you are and what a fantastic job you're doing. This project was funded by the WA Health Translation Network, who are really keen on having the findings taken up by the health service. And this is why this is a partnership. And then just to let you know, if you can travel next year, the next International Compassion Community Conference is in Belgium. So, yeah, anyway, something to aim for, September next year. And they've called it Democratizing Caring, Dying, and Grieving, which is like interesting. Yeah. So, yeah. Can you all see them, or should we have them on stage? Yeah. Somebody is missing. Is Luke not here? He's hiding. It's important to have men involved. So, Luke, we need to see you. And of course, we had Jeff Osborne, who's not here today. So there you go. Thank you very much for all you're doing. It's absolutely priceless. There's no, amount of dollar that we can put on what you're doing to the a morale of these families that you are helping. So thank you. Very humbled with working with you.